Assalamu alaikum. I'm Siddha Afreen. My roll number is BP1650191. I'm a student of 4th Prof Morning. My group number for presentation is group number 30. The topic which is assigned to me by my teacher Ms. Shahana is end-stage liver disease, and the subtopic is hepatorenal syndrome. Starting with end-stage liver disease. End-stage liver disease is basically due to cirrhosis, and cirrhosis is a condition in which scar tissues replace healthy liver tissues. Cirrhosis patients usually die of bleeding that can't stop, serious infections, or kidney failure. Cirrhosis disorder is basically a disorder of hemodynamics and altered renal perfusion. The symptoms which shows that the patient has end-stage liver disease may include easy bleeding or bruising, intense itching, abdominal pain, loss of appetite, swelling due to fluid buildup in your abdomen and legs, and nausea. Now come towards the main topic, hepatorenal syndrome. As you can see, hepato means liver and renal means kidney. So it is basically a disease of liver and kidney. Hepatorenal syndrome, it is the development of renal failure in patients with advanced chronic liver disease and occasionally fulminant hepatitis who have portal hypertension and ascites. Patients with abdominal liver function who develop ascites, hepatic encephalopathy, or renal impairment are considered to have end-stage liver diseases. Hepatorenal syndrome is the most common cause of hepatorenal syndrome is of portal hypertension and cirrhosis of liver. Hepatorenal syndrome is usually caused by narrowing of blood vessels that feeds the kidney, results in reduced blood flow to the kidneys and declining kidney functions. Hepatorenal syndrome is basically a reversible kidney failure in patients with cirrhosis, acute liver diseases, the history of hepatorenal syndrome. During the 19th century, Friedrich and Flint made the original description of renal functional disturbance in liver disease. They described oliguria in patients with chronic liver disease in the absence of proteinuria and linked the abnormalities in renal function to disturbance present in the systemic circulation. It is estimated that 40% of patients with cirrhosis and ascites will develop hepatorenal syndrome during the natural history of their disease. The diagnosis of hepatorenal syndrome is based on the presence of reduced glomerular filtrate rate, which is basically the GFR rate, in the absence of any other cause of renal failure patient. There are several types of hepatorenal syndrome. The type 1 is cirrhosis with rapidly progressive acute renal failure. Type 2 is cirrhosis with subacute renal failure. Type 3 is cirrhosis with type 1 or 2 hepatorenal syndrome superimposed on chronic kidney disease or acute renal injury. And type 4 is fulminant liver failure with hepatorenal syndrome. As you can see these diagrams here, it shows that the disease is traveling from liver towards the kidney. So basically the mechanism of this disease is like there is severe secretions in the liver which results to vasodilation, and due to that vasodilation hypotension occur, and hypotension may result in kidney failure. Now move towards the case study, the case related to this disease, hepatorenal syndrome. case states that a 88-year-old Chinese man presenting from a community hospital with a new onset of abdominal distension on a background of cryptogenic liver cirrhosis diagnosed on computed tomography scan, clinical history and physical findings were consistent with that of fluid overload. Investigations performed indicating acute kidney injury together with liver failure secondary to liver cirrhosis. The patient was diagnosed with hepatorenal syndrome in accordance with the criteria established by the International Ascites Club. The patient was subsequently admitted to the general ward of gastrology, where he was managed for hepatorenal syndrome, improved clinically, and was discharged to the nursing home. Now we will discuss the soap notes of this case, which basically tell us that how we can diagnose and treat this disease. So the subjective usually includes the chief complaint, history of patient illness or any other past medical record or any family history. So the given information of the patient which we have is the age of patient is 88, the gender is male, and the past medical history which we got of the patient is the patient has diabetes mellitus in the past. It has also hypertension, PAF, and sick sinus syndrome and background of cryptogenic liver cirrhosis. The objective usually includes the vital signs, physical findings, and the drugs which the patient usually take in his past. So there are the drugs mentioned which the patient took in his past. He used glycoside and metformin for his diabetes control, dyslipidemia, and enalapril for hypertension, and aspirin for PAF disease. There was no recent change in medication. Now, the assessment for the patient, we find assessment according to the subjective and objective of patient. So it's basically the information we gather from that and list the diagnosis. So the patient was provisionally diagnosed with hepatorenal syndrome. Differential diagnosis considered including fluid overload secondary to acute renal failure and deterioration of clinical condition secondary to underlying liver cirrhosis. So here is the plan, which is basically the final step and the diagnostic test, drugs and treatment we mentioned here, which we need to prescribe and treat the patient. The main drugs which we give in hepatorenal syndromes are albumin and vasopressin. We must know that what their function is in the treatment of this disease. So albumin infusions is effective in prevention of circulatory dysfunction after therapeutic pancreatitis or acute bacterial infections. And vasopressin cause vasoconstriction, improve effective arterial blood volume, and increase linear perfusion. That's why they are very beneficial for liver disease treatments. So the hepatorenal syndrome patient managed with an infusion of vasopressin and albumin in the emergency department. The doses of the infusions which we will give to the patient are mentioned here. The dose for vasopressin at a rate of 0.01 unit per minute and albumin 5% is 500 ml over 2 hours. IV insulin of 5 unit per hour and IV dextrose 5% in 500 ml over 8 hours were also started for the management of hyperglycemia. A nasogastric tube was also inserted for internal nutrition, giving a previous history secondary to right middle cerebral artery infarction with hemorrhage conversion. In view of the diagnosis, the patient was admitted to the general medicine ward. The patient diagnosis of hepatorenal syndrome was confirmed in the ward setting and he was managed accordingly. He subsequently improved clinically and was discharged to the nursing home. Now, the conclusion of this case study states that from the above discussion regarding medical literature concerning hepatorenal syndrome, early diagnosis and initiation of appropriate treatment is very important in managing this disease. We must start albumin and vasopressin insulin initially. The goal of pharmacological therapy is also used. It is used to reverse failure and prolong survival until candidates undergo liver transplant therapy. In liver diseases, complications may usually occur after 5 or 7 years, but when we saw the symptoms of some diseases which we have mentioned initially, so we must start the doses of albumin and vasopressin so that in the later time it may not be much fatal for the patient. I hope you like my presentation. Thank you for listening me. Have a nice day.